Right now, as you listen to this, your jaw position might actually be changing how your feet strike the ground. Think about that for a second. The modern human face has physically shrunk over the last few thousand years. And there is a serious argument to be made that this cranial collapse is actively breaking our ability to walk. Welcome to the debate.
It's a staggering thought, isn't it? We tend to think of our bodies as these perfectly compartmentalized zones. You have foot problems, you see a podiatrist. You have jaw problems, well, you see an orthodontist. But the reality of human biology is, frankly, far more intertwined than that.
And that intersection is exactly what we are dissecting today. We are faced with a really profound diagnostic and philosophical question regarding how we should fundamentally understand the mechanics of human movement, structural compensation, and ultimately physiological health.
Right.
The central question is this: are we to understand the body as a machine of isolated, conscious parts, a series of levers and pulleys perfectly engineered for locomotion? Or is it an interconnected, responsive web where mechanical forces directly dictate our unconscious nervous system and our energetic states?
Which is the absolute definition of diagnostic muddy waters. I mean, especially when we begin synthesizing classical anatomical texts, like Chapter 2 of Born to Walk, with our emerging understanding of evolutionary airway collapse from texts like Breath. Add in the autonomic nervous system regulation detailed in polyvagal theory, and even ancient Eastern meridian maps found in Zen shiatsu, it's a lot.
It is a lot, and that synthesis is exactly where our disagreement lies today. We are exploring whether human locomotion and posture are simply a series of localized musculoskeletal events, or if they represent a holistic, tensegrity-based fascial spring system that cascades into systemic dysfunction when compromised. I will be representing the classical, textbook anatomical view. My position is that movement is best analyzed through reductive, isolated muscle actions, joint ranges, and classical gait theory.
And I will be representing the radical systems engineering perspective. I'm arguing that the body is a continuous fascial web. Ground reaction forces, our evolutionary jaw structure, the vagus nerve, and eastern meridian lines are inextricably linked. You simply can't isolate one from the rest without missing the entire picture.
Let me begin by establishing the traditional perspective, because there is a reason it has been the gold standard since Vesalius first started mapping the human body. The old anatomy is profoundly effective precisely because it is reductive. It allows us to isolate variables.
Okay, but at what cost?
Well, at the benefit of actual empirical precision. When we look at human movement, particularly walking, we are best served by analyzing it through specific joint ranges and voluntary muscle contractions across the sagittal, frontal, and transverse planes. Walking is, fundamentally, a mechanical process. Efficiency in movement is the direct outcome of sequential, isolated events working correctly. In the literature, we refer to these as the essential events of the gait cycle.
And this is where we immediately diverge, because looking at isolated events in the human body is like trying to understand a symphony by only listening to the flute section. You're missing the music.
But if the flute player is out of tune, you don't need to analyze the acoustics of the entire concert hall to fix the problem. You tune the flute. Look, let's look at the mechanics of the foot rockers in Born to Walk. The heel, the ankle, the forefoot, and the toe. During the initial contact phase of walking, the heel rocker relies on the precise eccentric contraction of the anterior tibialis to lower the foot to the ground. If you lack knee extension, or if you lack knee extension during the terminal stance, your gait fails.
Fails locally, yes.
We can predictably trace pain or inefficiency back to the loss of one of these specific essential events. A restriction in the ankle joint predictably increases the workload on the knee. To introduce autonomic nervous system states or energetic meridians into this framework unnecessarily complicates a purely biomechanical process driven by gravity and ground reaction force.
I come at it from a completely different way. I entirely reject the reductive parts view you're describing. That classical model treats the human body like a stacked machine. Bones resting on top of bones like a game of Jenga, manipulated by isolated muscles acting as cables.
That's a bit of a caricature, but go on.
But humans are not stacked machines. We are biotensegrity structures. We are an interconnected, continuous, elastic fascial web. Human locomotion is not about isolated muscles firing in a vacuum. It is about gravity and ground reaction forces loading an interconnected fascial spring system to create slings that catapult us forward.
Okay, let's define tensegrity for the listener, because that's a term that gets thrown around a lot in, let's call it, alternative biomechanics.
Alternative, it's literally architectural physics, but sure. Tensegrity, which is a portmanteau of tensional integrity, works like a camping tent. The poles of the tent don't actually touch each other. They don't rest on top of one another to hold the structure up. They are held up entirely by the continuous tension of the fabric and the guidelines pulling against them. If you pull one rope tighter on the left side, the entire shape of the tent shifts all the way over to the right side. That is what our bones and fascia are doing. The bones are the tent poles floating in a continuous web of connective tissue. And furthermore, this mechanical web does not exist in isolation.
Here we go.
It is anchored by the physical structure of our evolutionary skull. It's heavily regulated by the autonomic nervous system via neuroception, and it maps perfectly onto the KO, which means depleted, and Jitsu, which means overactive meridian lines of Zen Shiatsu. When you isolate a muscle in a textbook, you are ignoring the spring system entirely.
I hear the tensegrity argument, and it is an elegant concept, I'll give you that. But let's look at the empirical data. Chapter 2 of Born to Walk dives heavily into the mechanics of the gait cycle. Modern gait studies rely on electromyography, or EMG readings. These readings show us with empirical certainty the specific muscle activations at each exact phase of the gait cycle.
Ah, yes. The magic of EMG.
It is empirical. We know exactly when the gluteus maximus engages. We know when the gastrocnemius fires. The EMG readings clearly demonstrate that when a joint loses motion, say you lose hip extension due to a sedentary lifestyle, leading to what we might call sensory-motor amnesia, it directly increases the workload on adjacent tissues. The mechanics are highly localized. If a muscle is weak, the EMG shows it is weak. The intervention is to strengthen it.
That is a compelling argument. But have you considered what EMG readings actually miss?
They measure electrical activity in the muscle. They don't miss motor unit recruitment.
Right. They measure voluntary, localized firing of superficial muscles. But EMG entirely misses the involuntary reflex reactions and the passive energy storage in the larger continuous fascial chains. Think about a kangaroo hopping.
A kangaroo?
Yes, a kangaroo. If you only look at the muscle contraction of a kangaroo, you would calculate that they shouldn't be able to hop more than a few feet. Their muscles simply don't generate enough force. But they bounce for miles. Why? Because of the elastic recoil of their fascial tendons. The human body does the exact same thing when we walk or run.
We are not kangaroos.
The physics are the same. The fascial web transfers mechanical force across massive body segments. We are capturing kinetic energy from the ground as strain within the elastic fascia and returning it as metabolically free elastic force.
So when we talk about sensory motor amnesia, the phenomenon where the brain literally forgets how to activate certain muscle groups because we spend 10 hours a day sitting in chairs, you don't view that as localized muscular weakness.
I think viewing it merely as muscular weakness is looking at the symptom, not the system. It is a systemic failure to engage the fascial catapults. Momentum and ground reaction force are no longer harmonizing with the skeletal joints. I mean, if you are listening to this on a walk right now, notice what your big toe is doing as it leaves the ground behind you. Are you actively pushing off through the big toe, allowing the plantar fascia to wind up like a rubber band under your foot? Or is your foot just sort of passively lifting off and falling forward?
Look, if they are passively lifting off, the classical approach says they have lost the toe rocker, likely due to weakness in the flexor hallucis longus or a restriction in the metatarsophalangeal joint.
But why did they lose it? The tissues aren't just locally weak. The mechanoreceptors embedded within the three-dimensional fascial web are not receiving the correct vectors of force from the rest of the body to trigger that elastic recoil.
I see why you think that, but let me give you a different perspective. If my car has a flat tire, I fix the tire. I don't need to analyze the entire chassis' resonant frequency, nor do I need to ponder the energetic flow of the electrical system.
A human body is not a Toyota, though.
It's an analogy. If a patient presents with a lack of hip extension, we address the hip flexors. We address the joint capsule. Why do we need to invoke a totalizing theory of their entire fascial web to explain a localized mechanical deficit? It just seems like an overcomplication of a simple mechanical failure.
Because again, the body is not a car, and it is certainly not a stacked machine. In tensegrity architecture, local tension changes a global shape. Let's stick with the foot mechanics. If you have a restriction in the ankle rocker, it immediately alters the vectors of force traveling up the tibia and femur. It changes how gravity interacts with the entire 3D web of fascia, across the pelvis, up the spine, and all the way to the cranium.
Okay, sure.
The fascial tissue provides the tracks through which mechanical information travels. You cannot isolate the hip flexor because the fascia surrounding the psoas muscle is contiguous with the abdominal fascia, the diaphragm, and the thoracic cavity.
But biomechanics already accounts for the kinetic chain. We know that a pronated foot causes internal rotation of the tibia, which causes a valgus stress at the knee. That is still mechanical engineering. Bone acting on bone.
But the bones only move because the tension network dictates their placement. You weren't just fixing a tire, you were trying to balance an entire web of interconnected tension. The fascia is physically composed of collagen, elastin, and a fluid ground substance. When it doesn't move correctly, the fibroblasts within that tissue lay down more collagen to brace against the aberrant stress. It physically thickens and hardens. A restriction below sends altered mechanical information up the chain, permanently altering the structure above it.
Okay, well, let's follow that causality then, because I know your perspective relies heavily on the structure of the skull as the anchor of this system. You're making a massive leap from foot mechanics to the head. You've argued, drawing heavily from the book Breath, that the fascial web is fundamentally compromised in modern humans due to evolutionary changes in our airway and jaw.
Yes. To understand why the foot mechanics are failing today, we have to look at the top of the tent. We have to look at the anthropological timeline. About 1.5 million years ago, our ancestors began cooking food. This led to softer diets. Now, ancient hominids, like Homo heidelbergensis or early Homo sapiens emerging 300,000 years ago, chewed for hours every single day. They were masticating raw tubers, tough meats, roots.
The mechanical force of which is significant, I'll grant that. We are talking about hundreds of pounds of pressure per square inch acting on the mandible maxilla.
Exactly. And according to Wolff's law, bone remodels under stress. This constant mechanical stress of chewing caused their faces to grow wide and pronounced. They had massive, wide dental arches and incredibly voluminous upper airways. But with the advent of agriculture, and specifically industrialization over the last few hundred years, we transitioned to soft processed foods. Today, 95% of the modern industrialized diet requires virtually no muscle chewing force.
And you are suggesting this caused an evolutionary mutation?
No, not a genetic mutation. That's the crucial distinction here. It is bioplasticity. Within a single generation of switching to soft foods, human faces begin to narrow. We see this in the fossil record and in modern observational studies of indigenous cultures transitioning to Western diets. Because the mechanical stress of chewing is gone, the maxilla, the upper jaw, doesn't grow wide. Instead, the roof of the mouth pushes upward, forming a V-shaped or high-arched palate.
Which physically encroaches on the nasal cavity.
Yes, it literally shrinks the nasal cavity, impeding airflow. The volume of the airway is drastically reduced in modern humans. We are looking at a species where 90% of the population has some form of malocclusion, meaning crooked teeth because the jaw is too small to fit them all. And 40% suffer from chronic nasal obstruction. Add to that the evolutionary drop of the larynx, which allowed us to develop complex speech, but made Homo sapiens the only animal that can easily choke on its food.
Okay, the anthropological data is robust. The physical shrinking of the human face is well documented. But you are linking this directly to locomotion?
I am. The consequence of all this shrinking real estate in the skull and the subsequent plugging of the nose is mouth breathing.
If you can't get enough air through a narrow nasal cavity, the body instinctively opens the mouth to survive.
And mouth breathing necessitates a forward head posture. You have to physically tilt the cranium back and jut the neck forward to open the collapsed oropharyngeal airway.
Exactly. And that forward head posture immediately and dramatically shifts how gravity loads the entire fascial web down to the feet.
That's an interesting point, though. I would frame it differently. Look, malocclusion is an orthodontic issue. Nasal obstruction is an ENT issue. I understand the kinetic chain, but you cannot seriously argue that eating oatmeal and smoothies for a few generations is the primary reason someone's foot mechanics failed during a walk today. Come on, you are stretching the bounds of causality to a breaking point. A high-arched palate does not dictate the mechanics of the subtalar joint during the stance phase of gait.
It absolutely does through the principle of tensegrity we just discussed. You cannot separate the anatomical structure of the airway from the mechanical efficiency of the spine and pelvis. Let's look at the physics. The human head weighs about 10 to 12 pounds. Think of it like a bowling ball balancing on top of a broomstick.
If it is perfectly aligned over the center of gravity, meaning the shoulders, hips, and ankles, the muscular effort to hold it up is minimal. The skeletal structure bears the load.
Right. But when the airway is compromised due to this evolutionary shrinking, the body will instinctively prioritize oxygen over posture every single time. It will jut that 12-pound bowling ball forward to open the throat. For every inch the head moves forward off its center of gravity, the strain on the posterior chain of the neck and back doubles. A head that is 2 inches forward feels like it weighs 30 pounds to the muscles of the upper back and neck.
I agree with the biomechanical math there. The suboccipital muscles, the upper trapezius, the erector spinae, they have to engage constantly to prevent the head from falling completely forward.
But remember, they are not isolated cables. They are part of a continuous fascial web. This constant, unrelenting structural tension alters the resting tone of the entire posterior fascial sling. The body is forced to use massive amounts of muscular energy to hold itself up, rather than relying on the structural balance of bones. This cascades all the way down. If the upper back is pulled forward, the pelvis must instinctively tilt, often anteriorly, to counterbalance the weight. If the pelvis tilts anteriorly, it internally rotates the femurs,
which pronates the foot.
The arch collapses. The mechanical efficiency of the foot rockers is lost because the top of the chain has collapsed. The flat foot is a symptom of the high palate.
I will concede that a forward head posture alters global biomechanics. That is mechanically sound. But you take this a massive step further by introducing the autonomic nervous system. You are arguing that this mechanical inefficiency is actually changing our physiological state of safety. You are taking a structural issue and making it a neuropsychological one.
I am, through polyvagal theory and the mechanism of neuroception. And I don't see it as a leap. I see it as the missing link. Our nervous system evolved to detect features in the environment to keep us safe. This evaluation of risk happens reflexively, completely outside of conscious awareness. Dr. Stephen Porges coined the term neuroception to describe this process.
Let's lay out the autonomic nervous system for the listener. Traditionally, we view autonomic influence as a paired antagonism, a teeter-totter between the sympathetic and parasympathetic systems. The sympathetic nervous system drives mobilization. It's the fight-or-flight response, fueled by epinephrine and norepinephrine. The parasympathetic system drives rest and digest, mediated heavily by the vagus nerve and acetylcholine. You are either stressed or you are relaxed.
But polyvagal theory reveals it is not a simple teeter-totter. It is a phylogenetically ordered hierarchy based on evolutionary development. It's a three-tiered system. The newest circuit is the ventral vagal complex, a myelinated pathway of the vagus nerve that promotes health, growth, restoration, and social engagement. We only access this state when we neurocept safety.
And if we neurocept danger, we drop down to the older system.
Exactly. We drop to the sympathetic nervous system, fight or flight. We mobilize to survive. And if mobilization doesn't resolve the threat, say if we are trapped, we resort to the oldest evolutionary pathway, the unmyelinated dorsal vagal circuit, which causes immobilization, dissociation, or shutdown.
like a reptile playing dead.
I understand the theory, but how does this relate to gait mechanics and a narrow jaw?
Here is the crucial synthesis. Neuroception doesn't just read the external environment, like a predator in the bushes. It reads the internal environment.
Meaning it reads the state of the organs and the structural tissue?
Yes, 80% of the vagus nerve fibers are afferent, meaning they travel from the body to the brain, reporting on the state of the viscera. If your body is constantly struggling to filter air through a nasal cavity that is 40% obstructed, and if your fascial web is constantly straining to hold up a forward head, what message do you think those afferent nerves are sending to the brain?
They are reporting mechanical strain and inefficient respiration.
They are sending constant unconscious cues of structural distress. The brain neurocepts this physical restriction as life threat or danger.
Okay, I'm not convinced by that line of reasoning because you're conflating a physical structural restriction, like a high-arched palate or tight cervical fascia, with a psychological or survival threat. A person with a high-arched palate might breathe less efficiently. They might have to take 16 shallow chest breaths a minute instead of 6 deep diaphragmatic breaths. But that doesn't mean they are in a physiological state of terror. They aren't experiencing the same autonomic cascade as someone being chased by a predator. Let's be real here.
I'm sorry, but I just don't buy that. Let me tell you why. You are still thinking of neuroception as a cognitive psychological evaluation of risk. It is not cognitive. It is entirely physiological and mechanical.
Explain the mechanism then. How does a shallow breath equal trauma?
When you breathe deeply through your nose using your diaphragm, the physical excursion of the diaphragm mechanically massages the viscera and stimulates the ventral vagal nerve endings located below the diaphragm. This afferent signaling tells the brain, we have abundant oxygen, our heart rate is regulated, we are safe. But if your jaw is narrow and your airway is small, you cannot use your diaphragm effectively. You resort to shallow, apical chest breathing using the accessory muscles of the neck, the scalenes and sternocleidomastoid.
Which are the exact same muscles recruited during a panic response to hyperventilate.
Precisely. The nervous system cannot tell the difference between I am chest breathing because my face is too narrow and I am chest breathing because a tiger is chasing me. The mechanical act of shallow breathing and the chronic tension of the neck fascia directly alter the subdiaphragmatic vagal pathways. The nervous system absolutely registers that as danger. We as mammals require massive amounts of oxygen. A restriction that oxygen flow, coupled with the chronic muscular tension of a compromised fascial web, prevents the ventral vagal state from operating optimally.
So you were saying that a loss of toe-off in the gait cycle stemming from a collapsed airway is triggering a continuous, low-grade survival response.
Yes. You cannot be fully in a state of social engagement, restoration, and structural ease if your body is structurally locked into a defensive posture. The modern mechanical inefficiency isn't just creating localized joint pain in the knee or hip, it is trapping the modern human in a chronic sympathetic drive or a low-grade dorsal vagal shutdown. The physical mechanical chain is the very environment the nervous system is reading.
That is an extraordinary extrapolation. I mean, if we restrict ourselves to the classical, empirical lens, we know that autonomic arousal can cause muscle tension. We all tighten our shoulders when we are stressed. We clench our jaws when we are angry. The brain tells the body to brace. But the reverse, that a biomechanical deviation in gait inherently disrupts the polyvagal hierarchy, that lacks empirical precision. It feels as though we are stretching a theory of psychological trauma deeply into the realm of orthopedics.
It is not stretching, it is integrating. The nervous system and the fascial system are not separate entities. Embryologically, they grew from the exact same folding of tissue in the womb. They are permanently wired together. And this integration becomes undeniably clear when we look at how ancient medical systems mapped this exact relationship thousands of years before we had EMG machines or functional MRIs.
Ah, yes. You're referring to Zen Shiatsu and the meridian lines. This is where I must draw a hard line on the demand for empirical evidence. It is one thing to debate the nuance of vagal tone. It is another entirely to validate invisible lines of energy.
Hear me out. Eastern medicine mapped the flow of energy, or ki, through 12 primary meridian lines. In Zen Shiatsu, disease or dysfunction is viewed as an energy distortion, defined by two relative states, kyo and jitsu.
Let's define those for the listener.
Kyo is the condition of being depleted, empty, hypotonic, or yin. It is a state of weakness or withdrawal. Jitsu is the opposite condition, overactive, stagnant, tight, hypertonic, or yang. It is a state of excess and tension.
And you are attempting to map these poetic, energetic concepts onto physical fascia and autonomic neurophysiology?
I am saying they are not poetic metaphors at all. They are astute, tactile, clinical observations of myofascial force transmission and autonomic flow. Let's look at your essential events of gait. What happens when a mechanical chain compensates for a lost essential event? Let's say the individual loses hip extension. The fascial tissue in the anterior chain, so the hip flexors, the quads, the abdominal fascia, has to work incredibly hard to compensate for the imbalance.
Yes, mechanically it becomes overloaded.
Right. It becomes dense, fibrotic, and mechanically tight. The fibroblasts lay down excess collagen. In shiatsu, this overactive, tight, highly responsive tissue is classified exactly as jitsu. It is fundamentally sympathetic in its nature, mobilized, overworking, hyper-aroused. It is flooded with local inflammatory markers and sympathetic neurotransmitters.
And the kyo?
Conversely, the tissues that are inhibited, like the glutes that are suffering from your sensory motor amnesia, they are literally shut down. They have withdrawn. They are hypotonic. They are kyo. They perfectly mirror the dorsal vagal state of immobilization and withdrawal.
Look, you're blending empirical anatomical science with philosophical frameworks. Localized muscle fatigue and fibrosis are the result of lactic acid accumulation, fibroblast activity laying down collagen in response to stress, and simple biomechanical wear and tear. It is a material biochemical process, not a jitsu energy block. When a physiotherapist or an orthopedic surgeon assesses a gait abnormality, they are measuring joint angles, torque, and tissue load, not invisible energy rivers.
But what is energy in the biological sense? Let's demystify ki. It is the transmission of force. It is piezoelectricity generated by collagen fibers under tension. The Eastern medical practitioners, relying purely on palpation and clinical outcomes, map the exact same continuous lines of pull that Thomas Meyer's anatomy trains model is only just now discovering empirically through deep fascial dissection.
So you are saying the meridians literally trace the fascial planes?
Exactly. Let's look at the bladder meridian in Zen Shiatsu. It starts at the inner eye, runs over the top of the cranium, straight down the erector spinae muscles of the back, down the hamstrings, the calves, and ends at the bottom of the foot.
Which perfectly mirrors the superficial backline in the anatomy train's fascial model.
Completely identical. They mapped where force traveled and where it stagnated. When a structural imbalance from a modern malocclusion shifts the fascial load forward, forcing the posterior chain to work overtime, force, meaning mechanical energy, literally stagnates structurally in the back. The tissue becomes dense, blood flow is restricted, nervous system flow is impeded by mechanical compression. Shiatsu uses the technique of tonification to normalize the empty kyo areas, bringing awareness and blood flow back to the inhibited tissues, and it uses sedation to calm the tight jitsu areas.
And you believe that this manual therapy is interacting directly with the autonomic nervous system.
I argue that this manual interface is essentially a direct physical intervention on the polyvagal system and the fascial tensegrity web simultaneously. By treating these functional distortions holistically along the meridian lines, the practitioner is balancing the sympathetic hyper-aroused forces and the vagal inhibited forces. They are telling the nervous system, via the fascial mechanoreceptors, that the body is safe enough to release the structural armor.
I appreciate the elegance of the synthesis, and the cross-disciplinary mapping is fascinating. I really do. But we run the immense risk of losing diagnostic clarity. The beauty of the classical model is its precision. If a patient comes to me with plantar fasciitis, the classical approach is highly effective. We analyze the foot rockers. We see that the forefoot rocker is failing, which increases the tensile stress on the plantar fascia during the propulsive phase of gait. The tissue is tearing under the load. We prescribe specific, isolated, eccentric exercises to restore the strength of the calf and the mechanical event of the forefoot. It is testable, it is repeatable, we can see it on an ultrasound.
And does it work permanently?
In many cases, yes. But when you say the plantar fasciitis is actually a manifestation of an obstructed airway causing a neuroceptive threat response that manifests as a jitsu stagnation on the bladder meridian, well, you have created a diagnostic model so vast, so interconnected, and so abstract that it becomes nearly impossible to test or treat systematically. Where do you even begin? Do you refer a foot pain patient to an orthodontist? It paralyzes clinical intervention.
That is a very fair, valid critique of how daunting the holistic model can feel. It is overwhelming. But consider the reality of clinical practice for a moment. Ask any physical therapist how many patients with plantar fasciitis or chronic lower back pain return month after month, year after year, despite perfect, evidence-based, localized treatment.
Chronic pain recurrence is certainly a significant issue in orthopedics. That's true.
Because fixing the local part doesn't change the global systemic tension. If they are mouth breathing due to an evolutionary skull bottleneck, and their nervous system is subsequently locked in a sympathetic state of low-grade panic, their posterior fascial chain will remain chronically taut. The brain is continuously commanding the tissue to brace for impact. You can massage the foot all you want, you can do calf raises until you are blue in the face, but you are treating the victim, not the criminal. The foot is just the weak link where the systemic tension finally snapped.
So your contention is that unless we address spatial alignment, breathing mechanics, and the autonomic feeling of safety, localized structural repairs are just temporary band-aids.
Exactly. We have to treat the whole tensegrity structure.
I will concede that the classical model struggles profoundly with chronic, systemic pain syndromes that defy simple mechanical explanations. The phenomenon of somatic alienation, the way our urbanized, sedentary lives staring at screens, disconnected from varied physical environments, has undeniably degraded our movement literacy. The clinical text you reference point out that we are facing a crisis in what they call kinesthetic intelligence. We literally do not know where our bodies are in space anymore. On that, we are entirely aligned.
Yes. The sensorial motor amnesia of our texting young and our debilitated elderly. We are living entirely urbanized lives, wearing cast-like shoes, walking on perfectly flat artificial surfaces, eating soft food, and perpetually stressing our nervous systems with digital information. We are disconnected from the very ground reaction forces and natural movement patterns our bodies evolved to utilize.
And I think it is precisely because of this profound physical disconnection that we must rely on rigorous, reductive anatomy to guide people back to movement safely. We cannot just tell someone to balance their meridians or feel safe if they don't even know how to activate their glutes. We must teach them how a hip joint works, how a foot rocker operates. The enduring value of precision, of empirical joint mechanics, is that it gives us a concrete, understandable map to diagnose specific movement dysfunctions. The parts view provides a necessary scaffolding for the layperson to rebuild their kinesthetic intelligence.
I agree that the classical map is a brilliant teaching tool. It is where we all start learning anatomy. But the scaffolding must eventually hold up a whole building. My hope is that the parts view and the holistic view can eventually be married in clinical practice. We need a grand theory of movement literacy, what the literature is increasingly calling spatial medicine, where we understand that changing your structural body position changes your mind, and changing your autonomic state literally changes the physical density of your structural tissue. Human beings are evolutionary biotensegrity springs. Structural airway collapse, vagal neuroception, and the flow of mechanical energy are completely integrated realities of the human experience.
It is a staggering level of complexity to consider. If there is one thing this debate illuminates, it is that to fully appreciate the human organism, whether diagnosing a gait abnormality in a runner, evaluating chronic physiological stress in an office worker, or sensing energetic stagnation, multiple perspectives offer unique utility.
We are vastly more complicated than simple levers and pulleys. Every step we take down the street is a dynamic negotiation with gravity, deeply intertwined with our ancestral past,
the shape of our faces, and our internal, unconscious sense of safety.
Image or an EMG reading could ever capture. There are vast, unexplored depths regarding how our physical steps interact with our internal architecture. We will leave it there for today and let you, the listener, synthesize these paradigms as you take your next walk. Notice your breath, notice your big toe, and notice how it all connects.